And I've never had someone, as when we met before, I've never had anyone who's done uh, geriatrics or old adults before. Um, why? What made you pick geriatrics? Of all the specialities in medicine to pick across, what was it about Jerry's that made you go, that's for me?
So I did always want to be a pediatrician. So
Ah,
throughout medical school, I had my sights set on it and built my CV to do it. And when I got there, I just thought, oh my gosh, what am I thinking? I can't do it. And then as I went through the hospital specialties and I did hospital, and I really liked all the hospital specialties, and I really liked being hospital, having a team. So I, ruled out the community side of things and knew I wanted to stay in hospital. But I always, I did respiratory and thought, oh, what about that other symptom that they've got? I really want to look into that. And I did nephrology. I really love that. So kidneys. But I really, again, patients with kidney problems get unwell with so many other problems, and then you end up referring out to cardiology for whatever's going on with their chest pain, or rheumatology for whatever's going on with their bones. And I thought, oh no, I want to know about all of it actually. So I think that's how I went in hospital. Then if you want to be a generalist and look after the whole body, there's really geriatric medicine or there's acute medicine.
yes.
Those are the main two specialties. And I don't really, I don't really like looking after young people, to be honest. Yeah, it's a thing that all my juniors know that puts me in the most grumpy mood in the morning is if I've got a younger patient on my ward who could be anyone under the age of 60, according to me. And it makes me very grumpy. So I love talking to old people and I love hearing about them and I love the whole person and, biopsychosocial, all of it.
Yeah. Because they'll come with a lot of stories
A lot of
from
stories, yeah.
my experience and a lot of life experience.
Yeah.
They've seen, compared to younger people, you say anyone under 60,
Yeah.
they'll have seen a lot more stuff and been through more things that a lot of population now can't relate to, I guess, can they?
Yeah.
Couldn't
Yeah.
understand.
No.
That's interesting. And going interested in peds, that was where
Yeah.
and you
For
complete the
5
other
years,
end.
I was interested. For 6 years, I
Really?
was interested. Yeah. Built my whole CV towards it, everything.
Wow. And then jump to the other end.
Mm.
Does it take a certain type of person then to work in geriatrics? To be able to sit
Yeah.
there and listen?
Yes, I think so. I think you're genuinely curious about people. I like to think that we're all a bit nosy
Yeah.
and we really do like want to know what next door Margaret's cat's called and what your sister did and what you did for a living and what you like to drink and where you went dancing when
Yeah.
you were 19 and how
Yeah.
you met your husband and yeah, all that nosy stuff. We're all a bit like that. We all can't get enough of the stories.
And I guess with Jerry's, from my experience, it's a slow change. Whatever your treatment you're doing, it takes time. It's not like, especially with peds, they turn around quickly,
They do, yeah.
but our older adults take a bit more time. Do you have
I
to be?
mean, sorry.
Does it involve a certain personality to not get the instant gratification, or can they quickly turn around?
I think it really depends on what you're treating. It can be a quick turnaround, and you really, um, you can see that person our, on their first 12 hours or 24 hours in hospital with sepsis, and you think, my goodness, did that person ever walk, and will they ever walk again? When they're in bed, they look really, really, really frail and crumbly, and yeah, you do, if they're septic and you give them the antibiotics and they get better and they're walking in within the next 24 or 48 hours, it can be that quick. Um, and that's when you have to have that experience, but you also have to keep the faith that, do you know what? She's got that twinkle back in her eye and she's gonna make it.
Yeah.
Yeah, it can be that quick.
Is there? I was thinking as you were saying about peds. I don't deal with kids, but there's always the element in the room with the parents.
Yeah.
But with Jerry's, you have almost a flip where you have the element of the room of the older child. Um, and as you were talking about, I was thinking, oh yeah, and there is that thing because obviously adults will have, it's with older adults, a middle-aged-ish child come in.
Yep.
How do you find those conversations when you're having to manage both the older adult and then their child who is worried and concerned and not knowing what to do when there's all these different problems going on and the multiple medications and all that jazz?
Yeah, and that's essential. And that is as essential as keeping the parents in the loop. You would never treat a child without telling the parents what's going on. And you would almost never treat an older adult without letting their next of kin, whoever their nearest and dearest are, of letting them know. And this is what I try and drill into the juniors at the start of their placements. And as to why it's so important to update the next of kin that day. You would never do that to a child patient, would you? You wouldn't dream of not letting the parents know what had happened that day. It's the same thing, because that older patient of yours may or may not be able to relay anything back to their loved one on the end of the phone or at visiting time when they come. They might remember, they might not remember, they might have got muddled up with who you were, who came to see them, what was said. It's very confusing on a ward round. You're met for 10, 15 minutes. And what did they say that they were going to do? Something through a drip and then some scan, or, it's very, it's not easy to keep hold of all those details. So it's so essential to keep that other family member, carer, loved one, next of kin, whoever it is, in the loop. And that's, very similar between those two specialties. It's very, very similar.
What if, again, I hear about this with parents, so I presume it, and I haven't experienced it a bit with adult children. The expectations aren't always in line with what we're suggesting, perhaps. And how do you manage that conversation where the older adult is expecting some form of care or outcome, whatever it is, and that's not actually going to be that care or the outcome that's best for their parent, or that their parent has perhaps agreed to?
Yeah. And those are the most difficult conversations that I actually do have. It's hardly ever the conversation with the patient themselves are the most difficult, actually. It's the patient's children and where they're coming from in terms of their expectations, but also their relationships that they've had. We can't know what relationships people have had. We can't know. There's no way of knowing, no matter how much time you've got. And I wouldn't want to know, but I think it's important to bear in mind that they are coming with some amount of background baggage, and that's why they are behaving in a way that they're behaving. Often it's guilt, often it's I wasn't there as much, whether that's based in any reality or not. People are still allowed to have, guilt. I wasn't there enough, I didn't do enough, that's why this happened. And now that I'm here, I want to make sure I do everything. And I do everything is where those unrealistic hopes, maybe not even expectations sometimes, definitely not demands. Usually they don't demand, but it's those unrealistic hopes. Why can't you do more? Well, why is the drugs not working? Well, why can't you call another doctor? Those things. And those are much more difficult conversations to have than having with the patient. And I think patience is the key, and letting them outpour whatever they've come to you with. And at the end of it, usually time will tell. It's not something that I'm denying the patient a medication, a drug, a consultation, a specialist, a scan, or anything. It's more times than none, it's nature taking its course against everyone else's best efforts. It's nature taking its course, and time shows them. And I think giving that person the opportunity to tell their side of the story, to be able to offload what they've come with, really does help with that. And I always say to the juniors, and the juniors will say sometimes that the more bolshy ones will say, well, why did you back down? That's a obvious, you're the consultant, it's a medical decision. In law, it's a medical decision. Why did you back down? And I said, well, it's sometimes you have to think about the people that are left behind, because they're going to have to be happy with the decisions that have been made. Okay, it's not my decision, or you say it is my decision in law, but actually it has to be a joint decision If the patient is too frail to be involved in that decision, it's the relative, it's us as the medical team, and they have to be able to live with themselves at the end of it. And so you really have to tread carefully, because you've only got one chance of getting this right, for that family. And people will say to me, well, don't, isn't your job really depressing? And don't a lot of your patients die? But yeah, but I can't stop them from dying. They are, maybe we're going to die anyway, but I can make those times as easy as possible for everyone involved. And those are the kind of things you have to bear in mind when you're trying to get that right at the end, because you only get it one chance to get that right. The people are only going to die once, and the people that are left behind have to be comfortable with the decisions that have been made and the way that things have played out. And sometimes it's families against each other as well, and we have to negotiate that as well. We have to help them find some kind of middle ground between them. And I've in the past implored, just please ring your sister, just for the sake of I know you don't want to have a conversation or a relationship, that's fine, but just do this and make one phone call, and just, you will regret it if you don't, that kind of thing. And I think it's not written in a book anywhere. It's not, it's not anywhere, but just from experience and from a position of, you don't want to be left with people having regrets because you've pushed something on someone, or not let someone have this say. I'm not saying we do things not in the best interest of the patient, but it takes patience to let that person explore and explain what's going on for them.
Do you think you've brought some families back together in the time?
I like to think so, yeah. I can't think of anyone in particular, but there have been some that haven't seen each other, and I've kind of implored them to make that call even for that moment. And obviously the pieces have to be put back together way after they've left our ward, don't they? So who knows?
And as you say, this all takes a lot of time. Because these are people with typically, not always, but typically multiple medical conditions, medications, as you say, various social situation depending on care needs and whatnot. And these conversations, regardless of whether you're in a hospital ward, in a GP room, in an outpatient environment, will typically take longer because there's more to get through. But you and I both know, working in a public healthcare service, we're not always blessed with time.
No.
How do you find managing time when there's a lot to get through, and with potentially people that have a lot to say and stories to tell us as well?
Yeah, I mean, I think you have to kind of get good at focusing on the issue. I think if you let people talk, they will tell you the answer. So it does save your time in the long run. Because you don't have to think about all those questions you need to ask them. Because if you let them talk a little bit at the start, they'll give you the answer to the problem, what exactly had been going on, and then this happened, and then 20 years ago I actually had this operation. I wonder if it's got anything to do with that. And you might not have ever got that answer, or that 20 years ago I had this operation bit of it. But it is true, people do love to tell stories, and sometimes you have to kind of have your spidey senses about you, where you think, not sure that bit's relevant. And I will often find myself saying to patients, I'd love to hear about this, but can I just talk about this so we can make you better, or so that I can come back in the afternoon. When I was a junior, and I used to love night shifts for this reason, because you had that little bit of extra time, or it felt like you had more time in the middle of the night to talk to people. And I love chatting to people who were awake and wanted to chat in the night, because you get to know all those little bits, and you're not like pulled in so many different directions. Well, you weren't when I was a junior doing nights anyway.
And is that your method of bringing them back? They're
Yeah,
saying, I'd love to hear more
I'd
about the.
love to hear more. Yeah.
Because I think
But
that's one of the biggest challenges,
yeah.
is where there'll be a bit of a tangent. You're having to judge, is this relevant? Is it not? It might be relevant, but I can't quite. And then eventually it'll
Mm.
get to a point that probably isn't relevant.
Yeah.
Some people often say if they start talking about something else and speaking off to the distance, um, saying their name, and that brings the attention back,
Mm.
or like a gentle touch on the arm as you
Mm.
do it, that it kind of brings them back to the room. But I've never heard that one before, actually. I'd love to hear
No.
more, but and that's usually brings them back most of the time.
Yeah. Yeah. Because they hear that you're interested, or you've listened, or you're listening, and then they're so grateful, as in, they just, oh yeah, of course, dear, you must be very busy. And then I feel bad that I said that, because they'll say, oh, of course you must be very busy, you don't want to sit and listen to me. Oh no, I do. I do, honestly, but I just haven't got all that much time left.
No. Does anyone ever resist it out of interest? If they can,
um
they try to keep
Resist it.
going.
Yeah, oh yeah, yeah, they do.
But you
There's
just have to get more
plenty, and then
firm
I
every time.
try and be more firm, or
Mm.
then maybe distract them with, your tea's gone cold, or your tea's going to go cold. Why don't you drink this before it gets too cold, and I'll come back and see you later, or something like that.
And that's usually effective. Everyone, they like their tea, won't they?
Yeah.
Now, obviously, some of these patients be on a scale of, you mentioned about earlier, confusion and remembering, and memory ability as we get older. And I realise we're not specifically talking about dementia today, but some older adults will have dementia, of course, or some degree of confusion,
Mm,
um, especially in an inpatient ward where there's lots of bells and whistles going on. The
mm.
routines change, the medications have changed, etc. What have you found to be the best ways to kind of reorientate them or help manage that confusion when they're in a
So
new environment?
delirium's very important, isn't it? To recognize delirium carries a big risk of mortality, morbidity, increases length of stay in hospital. So for people who aren't familiar, the way I explain it to patients, the way I explain it to relatives, is when your brain is under pressure because your body's got so much that it's dealing with, for example, pain
Yeah.
or an infection or a new environment, your brain just checks out for a little while. And
Oh,
that's what causes a temporary state of confusion that we call delirium, and it's usually reversible. So that's how I explain it to relatives, and they usually understand. Your brain is under too much pressure, can't cope with daily, why doesn't, when they say, why doesn't my mother recognize me, why is she talking about 50 years ago, why isn't she remembering,
yeah.
where she lived? That's how I explain delirium. And I think that, the most important thing about delirium is to try and figure out the underlying cause and treat it. um, it's where continence is so important. Bowels or bladder are, the biggest causes. You've got the infection under control, or you're trying with antibiotics. You've got their pain under control. If they've had a fall or they come in with a fall, you make sure that there's nothing underlying. But also, unrecognized pain is a good cause of delirium,
Yeah.
common cause of delirium. But if someone's bladder and bowel aren't functioning properly, that is a massive cause of delirium. So that's something that, if you don't look for it, you're never going to find it, because that person's never going to say to you, actually, I've been in hospital for 4 days and I haven't had my bowels open since before I came in.
Ah.
They might not tell you because they're delirious. They won't know,
Yeah. Yeah.
but they'll have a discomfort that they don't understand where that discomfort is coming from, or why. They won't be able to piece it together because, as I said, the brain's under too much pressure to be able to piece together that I've got an abdominal discomfort. I'm not really sure what that means, but it'll be adding to the delirium. It's amazing how once you clear someone's bowels or unblock someone's bladder, if they've got bladder retention, the delirium lifts. It's like
Ah,
magic.
really?
It's like magic. And I show, when if I have students on the ward, and the juniors as well, and they go away from their rotations on my ward going, oh, I'm never going to forget that. I'm never going to forget to check bowels. Check the bowels. Check the bowels. So important.
Is it a bit like because take us back to Pete again, where
Yeah,
obviously they can't communicate in the usual ways. So you have to rely on cues and other aspects. Same thing with a delirious older adult. You're having to rely on
yep,
those kind of things as well.
yep, yep, exactly. You do.
And like where they're sore, where they're point,
Yeah, where they're holding on to, where then,
yeah.
they someone will say, "Oh, well, they've been, asking to go to the toilet every 10 minutes, but nothing's coming." Okay, let's look into that then, shall we?
Mm. Now, continence is your area of expertise in
Mm.
older adults, is that right? Why continence in older adults? A very, very niche area.
Well, it is and it isn't. So it's one of
Ah.
the original geriatric giants that Bernard Isaacs came up with. So the
Mm.
four geriatric giants: intellectual instability, uh, immobility, instability, so balance problems, and incontinence. But
Oh.
it's the Cinderella of them. It's the one that's got the least kind of education behind it, the least the research, I suppose, the least amount of training. But it is one of the original geriatric giants.
Oh.
Um,
And because I was thinking when we were preparing for this, there'll be tons of again older adults who we may all see day to day who come into our service who mention about some bladder or bowel issues, and oh, it's just down to me age. Oh, I think I'm
mm,
at that age.
mm,
But I'm going to make the assumption that there must be more to it.
yes,
We can't just put it on the age.
no, because
Um,
otherwise everyone will be affected,
where should
and they're
one
not.
start with that conversation? If they've mentioned it, it may not even be why they're there
Yeah.
necessarily, but they've mentioned it. Where do you go from there?
Um, so that's a really good question, and I think that once you start talking about it, the floodgates literally open in that they just want to talk about more and more and more of it. So it's not that hard to get the conversation going. But in a setting which is not a specialist setting, it would be I mean, I would obviously just jump straight into it, but um even things like, do you drink enough? Because that's one of the big things that people don't do. Are you constipated? Because bowels impact on the bladder very, very strongly. So if someone's constipated, they'll get bladder issues almost 100% of the time.
Yeah.
Um, what do you drink? If you do drink enough, what do you drink? Because caffeine is a massive, massive um, irritant of the bladder. And I've had patients in my clinic who have 2 or 3 teas a day. That's it, and but referred to clinic because of having to rush with urgency and some incontinence on the way to the toilet, and they've eliminated those just 2 or 3 teas and switched them to decaf, and their symptoms have completely gone away.
Wow.
So you think you have to be sort of an 8 espressos a day kind of a person to for it to affect your bladder, but it's not true. Even 1 or 2 or 3 tea, not even coffee, can affect it quite badly.
And does that change as we get older so we can tolerate less?
Yes, yeah, that's right. Because your bladder irritability worsens as you get older. Your bladder capacity, so the amount it can hold, will get worse. That's factors of an aging bladder.
Yeah.
So if these things are sort of things that you can't mitigate against, so an aging bladder, your kidney function reduces, your ability to concentrate the urine reduces, your day-night cycle of concentrating and urinating kind of can flip with age as well. Those are things that you can't do anything about, but you can do something about the pelvic floor muscles. You can do something about what you drink and how much. You can do something about constipation. Those are things that you can help with.
Yeah, yeah. Is there anything that gets better as we get older, out of interest, apart from wisdom?
Wisdom, yeah. Sense of humor. Some of them are hilarious.
Because you hear all these things as pain and MSK land, everyone talks about the skeleton and muscles and
Mm,
um, um, and you can see why general public, if you get to a certain age, you start developing a problem, whether it's continence or pain or something else, you think, oh, it's me age. Ah, I've just reached that point now. That must be it. Um, the with the continence and the raising discussion, let's say uni, for example, where would you go if you've got obviously more expertise? We've mentioned the basics there about coffee and um, amount of drinking and constipation. Any other areas that one should inquire about?
Um, so I think it's so obviously in our clinic we look at the medications and see if there's anything that's tipping it. Um, we look at things like leg edema. So if someone's filling up with fluid in the daytime, that can lead to passing more at night time. So we look at things like that. Um, Obviously, some of the medications that are used for things like leg edema can work, like diuretics, can worsen some
Yeah,
urinary symptoms.
yeah.
So again, it's polypharmacy, complex comorbidity. Um, we look at neurological conditions. So many of the patients who get referred to the medical continence clinic have underlying neurological conditions. So Parkinson's disease often is hand in hand with bowel and bladder. And then for the younger patients, multiple sclerosis is sometimes hand in hand as well.
Okay. Are you picking those things up?
No,
Potentially.
they
No.
are patients that have got established disease that get referred into us. The places that those things will get picked up de novo will be places like Falls clinics.
Okay. Okay.
So when I was a trainee and I used to do Falls clinic, the odd time you'll go, oh, I've got a tremor and it's unilateral and they're walking with a shuffle, and I wonder whether I should send them to one of the Parkinson's specialists, and that's why they're falling over.
But by the time they get to you, it's normally well diagnosed and
Yeah.
established. Okay.
Yeah. However, they will tell us that their continence issues started way before the diagnosis of the Parkinson's disease.
Ah.
Yeah.
I'd be interested. I remember what you were saying earlier about, especially with expectations and time, and especially with older adults. These are people that are potentially on multiple medications, um, and you're having to. Some of them. Are we getting to a stage in healthcare where we're trying to cut that back or bring
Mm.
those back down?
Mm-hmm.
But these are people who've potentially been on it for decades.
Yep.
Uh, and they probably think, I need this to keep going. I need this
Yep.
medic. This is me now. I need that. How do you manage that
On
conversation?
on the wards, they love it. If you can slash their medications, they absolutely love it.
Oh,
Because their blood, they'll say, yeah, I mean, if I don't need it, get rid of it. If someone's had high blood pressure all their lives, but suddenly you're getting sarcopenia, you're not moving around so much, your vascular resistance is changing in your blood vessels, so your blood pressure goes the other direction. So you don't need all those 5 pills for high blood pressure anymore. You can get rid of the ones that are causing the worst, side effect profile, and keep some of them or keep none of them. Um, I love to get rid of statins.
ah,
Older people. I don't know if I'm going to upset any cardiologists, but if someone is extremely frail and don't really eat and drink very much, and sometimes they're on nutritional supplements, and you think, why are you then taking a nutritional supplement full of fats and proteins and taking a statin? That does not make sense in my simple little brain. But also, statins are given for 10-year benefit of prognosis. If you can clearly see this person in front of me does not have 10 years for whatever reason, they look extremely frail, live in a care home, maybe depend on someone for all of their care needs, it's one less pill they have to take.
yeah, yeah.
And they love it.
Do they
So
most of the time?
it's an easy conversation. In clinic, it's
Ah,
a bit more tricky because they go, I'm here for my bladder, and you're talking about my codeine, or you're talking about my this blood pressure tablet or this diabetes tablet. And I'm like, yeah, but I am a geriatrician, so I do know what I'm talking about in terms of, polypharmacy. But I don't, it is a more tricky area because obviously somebody's referred them in for medical continence, for continence
yes.
advice. And then I feel like,
Yes.
if I feel very strongly, I'll still do it. And I'll just
Ah,
put it in my letter that this is what I've done and why. But otherwise, sometimes, but again, I don't want to leave work for GPs to do, because if I've assessed it and I'm, a specialist in this area, which I am for polypharmacy and comorbidity and that kind of thing, why shouldn't I just say, yeah, I recommend we stop this, this, and this medication for this, this, and this reason, and there you go. But I don't want to make extra work for people. I don't want to ask them to do it if I've already made that judgment. Equally, I don't want to be stopping these medications and make extra work for them when the blood pressure shoots high or whatever.
Yeah.
So it is a balancing act, but if I feel very strongly, I'll still do it if I genuinely think this medication is not needed.
Yeah.
And the patients are usually just grateful that someone's explaining it to them, and I'll go through, this medication makes you hold on to fluid, and when you hold on to fluid you get leg edema, and when you get leg edema you sit up and wee all night, and if you explain that the mechanism as simply as you can, they'll go, oh yeah, okay, that's fine, but when I stop this your blood pressure might drop, so please drink a little bit more and pump your ankles and your your feet before you stand up, because otherwise your blood pressure might drop. And that's one of the things. I've done that before, and they've gone, oh yeah, that worked actually, and I'll bring them back to clinic, or I'll give them a phone call in a few weeks' time, even though my clinic's overbooked, and I'll say, how did you get on? I hope you didn't fall over, I hope you didn't, because that's the last thing I want to do is cause more harm.
Yeah.
And I go, no, it's a great idea, nothing happened, and you didn't fall over, and you didn't get dizzy, and his blood pressure was fine, and we managed to monitor at home. People are so happy to help themselves if you explain how they can do it, and you go, buy a blood pressure machine, have a little check on it. If he's feeling unwell and the blood pressure starts dropping, ignore what I've said and go back onto that tablet.
Yeah. It's almost, I think it's quite novel as well, because they're used to, by this point, seeing someone who's going to take this pill, take this pill, take this pill, and then you're going, nah, actually,
less is
the
more.
opposite. Yeah,
less is more sometimes, and they are quite happy to try stuff. Yeah,
and that works for relatives as well.
Yeah,
at the moment. Fun.
I mean, it is relatives that I'm explaining it to.
I guess it's less of a bag where they have to go get the prescription every month or whatever it is.
No, the partners they come with them. If it's a patient with Parkinson's, the one I'm thinking of is a patient with Parkinson's disease who had blood pressure problems, so they were prescribed this medication to help boost their blood pressure, but that was helping them hold on to fluid, which was making them wee all night, which meant they were absolutely knackered in the daytime, which made their falling over, their blood pressure, their Parkinson's symptoms all worse, because tiredness is a killer, isn't it? I mean, you've got, for young people, it's not great. For older people who've got any amount of, it takes that edge off their resilient, their ability to be resilient against these conditions that they have. They just lose their reserve if they've one more thing, which is being tired, on top of 1, 2, 3, 4 medical conditions that they're dealing with in the day. That's it. The reserve is gone.
Yeah, the cup is empty. Yeah.
Yeah, exactly.
And that's when the brain might then give up as well.
Yeah.
And then, yes, absolutely.
The sleep is so important. So if I can get someone to sleep better in the night, I will try to do that for, not getting up, passing urine. It makes a huge difference to their quality of life.
Yeah. Before we get to your hardest conversation, were there other things you want to say about the continence? What other things of our plan that I've missed that you wanted to say?
I think I really think that when trainees come to sit in with me at clinic, and they go, wow, I never knew it was made such a difference, and I always say to them, look, this is not rocket science. I know we're the only clinic in our area that's got a medical continence clinic such as ours. In other areas, if you're an older person, if you've got continence issues, you'll go to a urologist. If you're a man, you'll go to a gynecologist. If you're a woman, you might go to a urogynecologist. That's the most that there is in a lot of areas. You won't get a holistic person who looks at your neurology, your medications, your other medical problems, your bladder and your bowels together. And don't forget what I said at the start, that your bladder is impacted by your bowels so massively that your urology, your gynae or gynae are not going to be looking at bladder and bowels necessarily. Definitely urologists aren't going to. They'll just be looking at the bladder side of things, the prostate, the pelvic floor, maybe. Who's doing it all? Not many people. There are not many clinics like ours, actually. We are quite unique. And the trainees will go, wow, you made such a difference. And I said, yeah, but what did we do? Did you notice what we did? We listened to them. That's a big part of it. I say to my nurses, a lot of it is the conversation is therapeutic, because they might not have told anyone all of this in such detail, or any of it in any detail. They might not even tell the people that they live with for 5, 10 years. It's a taboo. It's embarrassing. It's they don't talk. But like I say, once you open the conversation, the floodgates will open. Whenever I do patient facing or public facing talks, like to charities and things. I've done a few public facing talks to charities, and there's a queue of people that have
Really?
got everyone's got a question.
Oh,
Everyone's got a question or a story or about themselves or about a loved one, about someone that they know that they want to know about. And it's a universal condition. It's a universal experience. It's not a universal condition, but it's a universal experience.
yeah.
Everyone can know what it's like to be continent, okay?
Mm,
And we can't remember what it's like to be incontinent because we were children, but everyone can imagine that
mm,
feeling. It's
yeah.
pretty universal. It doesn't not happen to anyone. You know, everyone's got that experience of being really desperate and having a toilet that doesn't work, or having a queue outside the toilets and having 2 pints of whatever and then being absolutely desperate. And people have got that experience in their heads. So it's pretty universal. And I'll say to the trainees, what did we do? And it's not rocket science. We didn't do that much, but I think it's the attitude that counts. It's the
Mm,
caring enough to ask those questions. It's the being bothered and thinking. And it's so true. The patients might have underlying cancer. They might be undergoing chemotherapy. They don't. What they care about is this symptom.
mm,
They want, this is what's affecting their quality of life, not necessarily the cancer or that horrible diagnosis or the Parkinson's. I mean, I had a patient in clinic who had just a couple of weeks ago who had Parkinson's disease. He was in his late 80s. He runs a Men for Sheds
yeah.
group, and
Manshed, yeah.
Men's in Sheds, men's
I think it's Manshed, isn't it?
man shed, yeah. And he was running that group in his local area, and he said that he wants to keep running that. So he wants his continence improved so that he can keep running that, because there's so many people
Yeah.
that rely on him in his late 80s.
Yeah.
um and his wife was saying the same. And um this is all that was stopping him, and you think that's all, and you could have said, yeah, it's his age, but I just, we just keep trying and giving that person some hope that someone is with them and someone is still trying for them and is not going to give up almost. And
Mm,
even at, when you've tried one thing, two things, three, four, five, when you've seen them a few times and you've kept trying, you have often made some amount of difference.
yeah.
And even if that difference is for them to feel that someone's given a really good try and to help them. Um, and psychologically, that makes whatever symptoms you are left with easier to manage,
Yeah.
because they don't feel like a burden anymore, because someone's done their best for me here and tried everything that they can think of. And really, there is nothing more unless I go for some kind of a invasive nuclear option, which we've talked about as well. We would have talked about as a last resort, things like bladder Botox and surgery and those kind of things. And but them knowing and feeling heard and seen and listened to, and that somebody's tried, almost always is enough to relieve that burden of the symptoms that are
Yeah.
left.
Yeah.
There's not many that have been left feeling, well, no, you didn't do enough. I'm
Mm,
still got symptoms. And those people had a lot more other things going on in terms of relationships, psychologically,
mm.
those kind of things, that were impacting on that feeling of burden.
Yeah. I guess that's power to asking, or at least definitely finding out, what does someone want?
Yeah.
Like, why are
Yeah.
they there? It's a bit
Yeah.
hard. Not quite, why are you there, but like,
Yeah.
how can I help? All that
Yeah.
stuff. Because
Exactly. Yeah.
they may have, as you rightly said, they may have 10,000 problems, but it's the one that's actually affecting their well-being or their
Yeah.
life. There's plenty
Yeah.
of things they may be able to tolerate and manage and carry on with. Um, but there's a reason they'll be sat or standing in front of us.
Yeah.
Um, and what
And
is it that,
sometimes when it is a bit confusing at the end of the history and the examination, and they've got 3 or 4 different symptom, and I'll often ask the question, now, if I had a magic wand today and I was able to wave it and get rid of one of your symptoms, which is the one that you want me to focus on first? not the only one, but which one shall I focus on today? And that's what really gets you sometimes get down to the nitty gritty of what it is that they value the most. And you can then focus, as you can't do everything in one go, and one thing does impact on the other. So it's useful to have that. What do you hope for? Which is the most bothersome thing for you right now?
Yeah.
Yeah.
Well, ask everyone this, or aim to. Dipti, what's been one of your hardest clinical conversations?
I think that it goes back to what I was saying earlier about conversing with families. I
Yeah.
think they are invariably the most difficult conversations to have, is dealing with the expectations, the weight of the baggage of whatever's gone on in those relationships in the past that we can never know about,
Yeah. Yeah.
but really giving the person some time to offload whatever they've come with, so that they can have room then to hear your side of the actual, the patient, in their mother, usually it is their mother or father, and you can talk about that. But you really have to be mindful that they are the one that's going to be left with
Yeah.
the weight of the decision that's been made. And how I really try and be very clear and say, look, this is all of ours decision. It's not on one you're not making this decision. I'm not asking you to make this decision. We are trying to make the best decisions that we can in the face of nature.
Yeah.
And we've got these tools, and we can use some of them, we can use all of them, or we can use none of them. Just because we've got them, it doesn't mean we have to use them. Just because we've got the drugs, it doesn't mean we have to give them. We can think about what the patient might have wanted, what you feel they might have wanted, and how well they're working. But I think having that in the back of my mind, it doesn't make those decisions easier. They are the most difficult decisions, the ones that you have with the loved ones, because, like I say, the nature will take its course, so we can't stand in the way of it, and we can't stop it. We're not in America, where people get life support machine far more often than we do here. But it's really important to think, I really have to tread carefully, because this person is going to remember these days and these conversations,
Yeah.
and have to live with them.
Yeah. We
Those are difficult.
they're going to be this person in our life who we see for 20 minutes, half hour, however long it is. But they're going to remember that 20 minutes, half hour
Yeah.
for the rest of time, potentially.
Yeah.
I remember, on a similar note, the expectations, this was years ago, being qualified, but I was on a stroke ward at the time. And this would be one of your older adults, had a rather significant stroke. And this was someone who was pretty independent beforehand, and had a lot of input, and timers weren't getting anywhere. And again, trying to support the family, there's a lot of hope and expectation that, could you with this? But it just wasn't getting, and it wasn't an easy conversation. And as you suggested there are multiple views, using the whole MDT, etc. I still remember it now. Yes, it did make it. It was still a hard conversation, but it's easier when you do it as a team. Which, wars like that there is, and yeah, it's. I think that we can apply that to any age, couldn't you? Whether it's geriatrics at one end, peds and parents at the other, or middle-aged and spouses. It's always going to be tricky trying to juggle expectations when they aren't always matching.
Yeah.
I always end these on the future.
Yeah.
In your view, what's the future for geriatrics look like, as our world will be changing over the next decades?
Well, I think that it's going to be us, isn't it? In the future. Well, me sooner than you, but it's going to be us in the next I think that it's really important to make sure that everyone who's, and I'm so pleased that many of the training programs now include geriatric medicine as one of their rotations, because geriatrics is everybody's business.
Yeah.
They are the people who aren't going to be able to go home quickly. They aren't going to be suitable for virtual wards, although we do have older person virtual wards now, but high tech in-home monitoring. Necessarily they're going to be the frailest and the sickest people who actually do need those walls around them, the hospital walls. And so it is going to be everybody's business, because there never will be enough geriatricians to look after them all. And so core geriatric medicine should be everybody else's business. And I think, as I said to you from the start, or when I said to you earlier, it is more about the desire and the will and the right attitude, because it's not really rocket science. It's not really requiring a specialist, type of computer or drug, or even specialist knowledge. Yes, it's a specialist skill set for sure, but a big part of that specialist skill set is the right attitude to care, to ask those right questions. Like you say, well, I've got all these drugs that I could use, but actually, what's important to you right now? What do you want me to do? Which symptoms are important to you right now? Not everybody wants to go to the cath lab when they've had a heart attack and they're 89 years old.
No.
And just because we can, it doesn't mean we should.
No, agree. Entirely agree. Yeah. No. Do you think the age at the moment, geriatrics, is anyone, we'll push my memory here, anyone over 65?
Yeah, 65 with frailty syndromes. Yeah. If they're over 65 and they're robust and fit and haven't got frailty syndromes, they don't have to be seen by a geriatrician necessarily. They can go to the single organologist if they, depending on what they've got wrong with them, what they've presented with.
Single organologist, I like that.
I didn't say the rude version of it. Single organ doctors.
Okay.
Which shortens to.
Yes. Could that change over time, the eligibility to be considered geriatric, as our ages might be changing, we might be living longer? Do you see that going to 70 or plus?
Yeah, I mean, I think that it certainly can, and I think that using the frailty syndromes to, like I said, there's going to be very many people who have those numbers. The age is only a number. I think that when we can stratify people into those needing the skill set of a geriatrician, will be those who have the frailty syndromes. So falls, polypharmacy, multimorbidity, delirium and dementia really should be looked after by geriatricians. Things like Parkinson's disease again. So those types of frailty syndromes and particular diagnoses can then be stratified to who goes to a geriatric ward and then who doesn't necessarily need to, who can be looked after by the respiratory, kidney, whoever, gastroenterology. Yeah,
those people.
Yeah.
Dipti, you and I connected on LinkedIn and X. Anywhere else people can find you?
No, those are really the main places where I am on social media.
Well, I can only thank you again for your time and being the first person to talk specifically about older adults and geriatrics. And I'm just very grateful. And thank you for coming along.
You're welcome. I hope it wasn't too rambly.
No, not at all. Not at all.